Welcome to another episode of the Living Well podcast. And today with us we have Dr. Seema Rao, who is Director, Education and Research of the Karunashray Hospice at Bangalore. Dr. Seema Rao, can I ask you to talk a little bit about your role in the hospice? It looks at cancer patients, but what is your role in the hospice?
So I primarily look after education and training, quality improvement within the hospice. Involves creating training programs, some of which even you are aware of. And it also involves in creating research activities within and quality improvement within the institute. In addition to that, I do also have a clinical role in providing inputs for psychosocial issues. My background is in psychiatry before I came into palliative medicine. So it's about providing those psychiatric inputs when needed with the patients.
And usually, what kind of psychiatric or psychosocial enhancement inputs do you find you need to, help with for these patients?
Yeah. So I think majorly, as you know, the prevalence of psychiatric issues in patients who have terminal illnesses is quite high.
Yeah.
It could be anything. It could range from anxiety disorders to adjustment disorders,
Yeah.
depression,
Yeah.
or even delirium, basically.
Yes.
So these are all aspects where the psychiatric inputs come in. Talking about psychosocial issues, I think the very diagnosis of cancer or any serious illness for that matter brings in a lot of psychosocial spiritual concerns.
Correct.
Right? So many of them sort of go through this stages of grief when they are diagnosed with, right? So it's about majority of them are able to sort of cope and adapt to this situation, but a few do develop psychiatric issues or mental health disorders.
I was very interested in knowing about the coping aspect. A diagnosis of cancer is actually sometimes it's like a life. It is always a life-changing diagnosis. How have you found? How do patients? And I think that the people, the people who come to Karunashray may have a lot of times either terminal cancer or incurable cancer. How have you found? How do people cope with an illness of this much severity?
It's coping. It's a very difficult process, right? It's very individualistic. So if you cannot group people together and how they cope. It depends on the person how they cope. It also depends upon the situation that they are in, and majorly it depends upon the type of illness that they have.
Yes.
Yeah? So the more dysfunction, more disability, more disfigurement, right? That is where the problem sets in. So to a large extent, it's also about individual resources, the personality, the individual resources that they have. When we talk in the psychiatric parlance, like, we call it coping strategies.
Yeah.
Okay, so there are quite a few that people use. One is, the anxiety, the fear, the sadness. You need to control that. So you use techniques to control that. It could be meditation or whatever. So emotions need to be controlled. There are a lot of decisions that need to be made during this time. Problems to be solved, practical treatment decisions, etc. So some of the coping strategies are focused around that, and seeking support, social support, what we call. It's about having a robust support systems,
Right.
because these you can't manage these issues on your own. You need a good support system that backs you up during these times. And finally, what we call the fourth is about meaning making. So these are all the different strategies that people use, when they are faced with stressors in life. Not only cancer, any stressor. It could be loss of job, it could be a breakdown in a relationship, or it could be the diagnosis of a serious illness.
So, if I were to just name the ones that you just spoke about, one is focusing on decision making. What needs to be
Absolutely.
done next?
Yeah.
What needs to be
What to be
done
done
next?
next?
That would be
Yes.
one.
Yeah.
The other is, like you said, that seeking support from either within or from
Those around you.
those around you, your community. And the third was
Third was controlling your emotions, right?
okay.
So we call it problem focused coping,
Huh.
emotion focused
Huh.
coping,
Huh.
seeking social support.
Hmm.
These are all
Hmm.
coping mechanisms. And the last one, primarily when you are faced with some stressor or
Huh.
a difficulty, is
Huh.
the meaning
Is
making part
meaning
of it.
making.
Yeah.
Okay. And is it that all these coping strategies can come together in a single lifetime or in a single time period when you are looking at a illness?
Illness. There are some good days, there are some bad days, and it's highly variable from person to person. So it's about what I need in that particular situation,
Hmm.
and many of the psychosocial support
Hmm.
that we provide
Hmm. Hmm.
focuses on helping patients identify what strategies work at what time.
I'm very interested to know how you have these conversations that
Yeah.
okay, you are in front of a patient, you are they are expressing some concerns and you are trying to help them identify the coping strategies. If you have a story or something that you remember with an interaction that you had.
Yeah. Yeah, so it's not like, it's not like the medicines that we give. Pain
Yes,
is there, so you
yes,
give this.
yes,
These things evolve over a period
yes,
of time.
yes.
So one of the most important things, what one of the patients, what we looked at was the meaning making part of
Huh,
it.
huh, huh.
So different people have different reasons for why they live. Even if you look at what gives
Yes,
us meaning to life,
yes.
what I feel is important, you may
Huh,
feel that it is very different,
huh.
right? So for one of the patients, it was her role as a mother that gave her a lot of
Hmm.
meaning,
Hmm.
right?
Hmm.
And loss of that role was one that caused the distress,
Okay.
right? So it's about bringing that back into the conversation with the family,
Hmm.
allowing her to continue to play the role of a mother.
Mother.
What happens in most families is the minute a person falls sick, they start getting treated as a patient.
Yeah. Hmm.
If you see in the conversations that I am having with you, I hardly say patient. It's a person who's coming to you with a disease. So when we start referring to individuals as patients, the families also
Yeah.
look at them that way.
Yeah.
And that sick role, what we give them in the home, can be very difficult for the
Yeah.
person to handle. So it's about bringing about that change and that paradigm shift, how the person views themselves as well as how the families view this individual.
So it's almost like giving some roles back or empowering them to kind of
Connecting them back.
have
Yes,
those roles
absolutely.
in place even as they are um, taking care. Um there was one thing which I've always thought of. You spoke about psychosocial spiritual
Spiritual.
aspects, and spiritual is also linked with religion, right? Now, in your experience, is coping different for people who are atheists as compared to those who are religious?
So, to a certain extent, it may vary,
Huh.
though the basic coping mechanisms are same. How they make meaning might vary between a person who's very religious and a person who's an atheist. So, religion can be both positive as well as it can have negative. So, for example, I had this lady who had come to me, extremely religious. One of the distress that she had is, despite doing all this, why is this happening to me? I have sinned. Probably I'm being punished for
Sinning.
the sinning. Okay. So that was the root cause of her distress, right? So it can be positive, it can be negative. Whereas an atheist, someone who didn't believe, another lady came to me and said, I don't believe in any of this rituals, when I explored about the spiritual beliefs. But at the same time, I'm at peace
Hmm.
because I've had a very meaningful life,
Hmm.
volunteering, doing whatever she felt had value.
Hmm.
She felt she had contributed significantly to the society. She had a very meaningful life and she's leaving behind a very stable family. So she was at peace with death, right? So it can work either ways. It's about how they make meaning that varies between those who are religious and those who are not. Another lady came with me who had the strong belief in karma. So she was okay. The suffering is a result of bad karma.
Yeah.
So I'm, finishing off my load of karma in this birth. I don't want to carry
To the
into
next
the
one.
next birth. So she
Wow.
was at peace. So, it varies. It varies. As I told you, coping varies very much, and the meaning making is very different.
So
And
it's almost like no matter what belief system you have, you you can always find something within you
then you
to be able to find.
find that meaning.
Yeah.
Yeah, absolutely. So I think the journey that we have as palliative care physician when we provide
Hmm.
psychosocial or spiritual care
Hmm.
is about, one is understanding where is this distress coming from.
Hmm.
Okay, whether it is an adaptive sort of a distress, or it is going maladaptive, whether there is any component of mental health issues that are
Yeah.
seeping into this
Yeah.
distress,
Yeah.
which can be treated adequately,
Correct. Huh.
identified and treated,
Huh.
and providing that space, that what we call is the holding space
Huh.
where the person can discuss these issues
Huh.
and make meaning.
And I mean, I know that see, a person who comes into a hospice may stay there for as long as few days to few weeks, and they will come with a whole lot of other physical symptoms also, complaints also. There may be pain, there may be a wound which needs taking care of. So we have to, as palliative care physicians, we have to look at that also, and at the same time see that we are able to adequately explore this area. uh, do you have set timelines of how long this takes? Because even these conversations can take long.
Absolutely. So timelines are never possible in palliative care.
Yeah,
I think that's
yeah,
that's one thing
yeah,
that we learn, isn't
yeah,
it?
yeah.
It also depends. Having these conversations require some amount of physical comfort.
Hmm.
If a patient is
Hmm.
in terrible pain, vomiting and having nausea continuously, or breathless, possibly it's very difficult to have and explore these
Yeah.
conversations.
Yes.
So, in a way, a patient whose physical symptoms are more or less controlled, I won't say 100%,
Yeah.
but more or less well controlled, is able to have these
Correct.
conversations.
Huh.
The conversations also depends upon the preparedness of that individual,
Hmm.
right? How prepared and how far along the journey they are,
Hmm.
right? To
Hmm.
have these conversations.
Hmm.
Do they know the diagnosis? Do they know the
Right.
prognosis?
Hmm.
Right? That also, I mean, that is when the preparedness happens, isn't it? When they know that this is an incurable disease.
Hmm.
Okay, it's a serious disease. It's going to be end of life, what I'm facing. That's when people start reflecting and looking back at their life, and
Hmm.
that's when we have these conversations.
Hmm.
So to a certain extent, the preparedness of that individual. Timelines very difficult,
Hmm.
but what we do, because we don't know how many days the patient may be alive with us, right?
Yes.
And maybe alive how long we have. So we make a concentrated effort to have these conversations every day, faster, so that you know but yes, it takes time, and that is where the concept of early referral
Is
is
important.
extremely
Hmm.
important.
Because nobody thinks about referring early just to help patients come to terms with their diagnosis or help people cope with the amount of problems that they have. We always link early referral with physical
Physical
symptoms, with
symptom
pain,
management.
or with a better rapport towards the end of life. But that's also a very important aspect, which we don't. Probably because in medicine we don't really focus so
On
much
these
on these
aspects.
aspects.
So, just to give you an example of one patient I had, this was just before our conference in January.
Mm.
The gentleman had come towards 21st or 22nd of Jan, when we were just about to go out for the conference. So he was a gentleman with 22 years back. He had renal cell carcinoma.
Okay.
Okay, he had multiple recurrences, had multiple surgeries, etc., and had some 20 years of cancer-free survival. And at the age of around 76, a different rectal cancer had come in. By the time it was diagnosed, it had already disseminated. Very frail individual as it is, because post last time surgery, he's had multiple issues, on and off, ulcer that was bleeding, multiple issues were there. So I saw him on 21st, very systematic gentleman who had written all his history. I just had to take a Xerox and put it in the file. It was like that. And I said, okay, there's time. He was asymptomatic with mild pain at that time, for which medications were given. I said, after 10 days, we will see you again and we will have a conversation. He wanted to know how things would progress, etc.
Yes.
Living with his wife and daughters. One daughter was abroad, another was living in Bangalore, in a little far away. So by the time I came back, within about 10 days, he had multiple episodes of hyponatremia and hypoglycemia, which we tried to correct. He was admitted in a hospital. His physician tried to correct, but he had gone into that spiral, which wouldn't recover, and he was extremely delirious, which couldn't be controlled at home. And here was a gentleman who wanted, who needed to control things. He was very structured in his life, and suddenly, in a span of 10 days,
he has lost control.
He has lost complete control, and his delirium was very severe. It was, I don't know what is happening, right? He was very perplexed, very confused. And we had to bring him in, though the place of death was home, we had to bring him to the hospice to control the delirium. So it was a sudden decline. And I was thinking, if I had only a few more discussions with him, he would have been more at peace at end of life. Right? So the sudden decline, when it happens, we don't have enough time to prepare. So that is when, death can be very distressing for the family, for him, for everyone.
But I know that you said a few things in which people actually find meaning by either saying that, okay, I have done all that I have come for to do. These conversations around meaning making, are they usually positive, or are they always negative, sometimes negative?
So these conversations are about life, which has both, isn't it? It's about their perceptions about life, what they have experienced, and their fears, their anxieties. While there are a lot of, they reflect a lot on what has happened in the course of their life. There would be positive reflections, there would be negatives. But everything has there is a lesson learned, right?
Right.
When you look back on your negative experience, you do look at what you have learned out of that experience. What do you, the growth that you have experienced.
It's almost as if every experience you go through, you will make meaning of it, and
you make meaning of it, and that's how it could be something as simple as probably moving from one city to the other and struggling to make your mark in that new city. So there's a meaning making everywhere that happens throughout your journey. So there's suffering, there's positivity, there's negativity in it, but it all leads to something. So I had this lady who had come from a very rural interior place, who had come with her husband, who had a head and neck cancer. The question that she asked me the first time she came was, why did he get it? He doesn't smoke, he doesn't have tobacco. People say if you do all that, you get oral cancer. Why did my husband get it? And we are so religious. We we pray, is this how God? And they are young. in their 30s,
Oh.
right? And at the end of about 2.5 months of going for treatment, coming, watching patients, she had a meaning of her own, right? It's about, I was so scared to get out of the house. Look at me today, right? The God has made me so brave that I am the one who's taking him around in a city,
Yeah.
which I would have never learnt
Otherwise.
otherwise, right? So God had a reason for why all this happened, so different ways people make meaning out of their experiences, and sometimes you learn a lot from them on how they see life. Only thing is, do we, as palliative care physicians, right, do we provide that space for them to do it? Sometimes it happens in our presence, sometimes it can happen with, within their, if they have a good support system, talking to each other within families also, they may do that.
And what does it mean when you say holding space for conversations like that? How do you know that, okay, I have now reached, say, in a consultation or in a conversation with a person, how do you know that you have reached this point? Is there a question? Is there some response that you get from them, and okay, I have done this now for them?
So it's about how you approach that conversation. It's about, we learn communication skills, right? We learn about picking up cues, correct? We learn about, responding empathetically in a compassionate manner. It's about verbal and non-verbal way that you can approach this. There's no one question. In fact, I remember we had this lady who was referred to me in severe distress. So she's again a 38-year-old with widely disseminated cancer, who kept talking about her life, how she struggled from childhood till this age, and her struggle continues. Right. So, and she was tearful, she was so bitter, she was so angry about what her life was all about. So I was just listening to this and I was thinking, where do I go from here? I didn't know where to go, right?
It doesn't look like there's any
ray
of
yes
light.
Because it was so dark. That was when I really don't know how I did it. I just asked her one question about what were you doing when, what would you like to do before all this started? What are the things that you used to enjoy? And that's, I like listening to music. So I said, can you sing which song? So she spoke about one Kannada song sung by a famous actor, Rajkumar, okay, which talks about, which was very dark and very painful. The song was about how God is playing with her. She's like a rag doll. He's not finished playing with her. He's breaking one leg, playing around with her. But still he's not finished with her. Right now again, so dark.
Yeah.
Right? So I didn't know how to respond to this, but I knew one Rajkumar song which spoke about the exact opposite of this. So I sang it to her at that point. And that is when, I don't know whether you call this therapy, but that connect happened, right? And then we were able to proceed on to talking about, what do you call it? Re-looking at her life, the positive aspects of what she had experienced. And in a day or two, she told me it was not all negative.
Wow.
She did have support from her brother, so the conversation changed a little bit. But when you ask me, how did I reach that point? It happened intuitively sometimes. If you are open to the experience, spiritual care, there are steps to spiritual care. There are skill sets, but it also needs a lot of openness. Letting yourself into that experience in that space and being very intuitive to what is happening.
Wow, that's a scary song. I didn't know that there is a song like that. No, yes, all of this is, there is so much negativity around the diagnosis of cancer, but it's almost like when you talk to the family of a person who has been diagnosed with cancer, they always want to keep it positive for them.
Absolutely.
So I'm also wondering, is this a kind of toxic positivity that we try and keep so hard, we try and keep up this around our loved ones so that they don't get affected?
Absolutely. I think the whole language and conversation of around cancer is about what I would say toxic positivity,
Mm.
right? We want to fight
Hmm.
the cancer,
Hmm.
right?
Hmm.
It's a cancer warrior,
Yeah, yeah.
right?
You're a
Okay,
cancer warrior,
you're a
correct.
cancer warrior,
Huh.
right?
Huh.
The whole conversations from
Huh.
the medical perspective also, we sort
Huh.
of emphasize on being positive,
Yeah.
right? It can be toxic, as you
Yeah.
rightly said. It can be very toxic,
Huh.
not giving space for pain, not giving space for anxiety,
Huh.
not giving space for grief,
Hmm.
right? We have to be positive all the time. In fact, when we talk also, we put all the onus on the patient. If if you're
Hmm.
very positive, good things will
Yes, will
happen to you.
happen. Yeah.
So if my cancer progresses, it's because I've not
I
been
was not
positive enough.
positive.
Okay. And it's I who am failing chemotherapy.
Hmm.
The
Hmm.
patient, has
Hmm.
failed multiple lines of
Yes.
chemotherapy,
We say
right?
that
We say
so
that no,
often. So
it's
often.
not that the disease has progressed, or the onus is on the disease, not on the patient, right?
It should be.
It should be.
Yeah.
It should be on
Yeah.
the disease,
Correct.
right? So, um, you know, either the doctor has failed, we have failed multiple lines of chemotherapy. So the onus we put on the patient.
Yeah.
So I think it's become the norm. I think it's time to rewrite that story. Battling cancer,
Battling cancer.
managing cancer.
Hmm.
It can be an alternative, right?
Yeah. Yeah.
Right.
Yeah.
And also, one of the things I think I tell when if I get them early on,
Huh.
when I was working in KMC Manipal, some of the patients used to come very early. So one of the things that I used to tell them, it's okay to be sad. It's okay to be scared. It's fine to cry. You don't have to be positive all the time. Also, you cannot handle this alone. It's important to identify people who can be with you. Even at 2 o'clock, if you're scared, whom you can call and talk. That there will be people around. So
Yeah.
I think having those conversations right in the beginning is very important. It sets the tone for the cancer journey.
And this thing about an early palliative care consult, as in the palliative care fraternity, we keep talking about it so much that it's very important. But a patient comes to you, say, metastatic or locally advanced cancer, but planning for a lot of therapy, whether it is chemo, whether it is radiation, so expected to have at least some good months to maybe years of good survival or good quality of life. No, not many symptoms. What would you do at a consult like this? What would you do at an early palliative consult?
Yeah. So I think that is where you get an opportunity to talk more about non-physical symptoms, isn't it? Right? So for example, if the physical, there's nothing much to talk about because patient is still hope of control or cure is ongoing, right? It's important to then look at how do they normally cope, right? And to sort of, give some sort of psychoeducate about, see, as I told you, it's important that you have a set of friends,
a
right?
close circle.
A close circle. It's important to lead as normal a life as possible. You don't have to be a patient all the time.
Correct.
Right? You can lead a normal life. Okay. It's also about probably a little bit about compliance, how compliance for treatment is extremely important, and what are the things that you need to look out for. It's about educating them about the side effects, what can happen, what thoughts can come in, what are things that they need to watch out for. Having information. Information is power.
Yes.
Right? It gives you a sense of control.
Yes.
Right?
Yes.
When you know what is happening, you have a sense of agency, what we call a sense of control.
Yeah.
And that sense of agency reduces anxiety, fear, etc. Also, in case something happens, what the crisis plan that you have in place? Talking about all that, right? It can be unpleasant, but it also works in making patients more comfortable with the situation.
And what about scenarios in which a family comes to you and says, this is something we have heard a lot of times, that she or he doesn't know that they have cancer. Don't tell them. They will get depressed. They will not take treatment. They will not leave the house. This is especially a lot, I think, in our Indian framework.
Absolutely.
Because we are always about protecting our loved ones, and we don't have that sort of patient autonomy that the West, thinks of as the ideal. For us, it's a little different. How do you tackle these kind of questions?
It's very common, actually. In fact, we are doing a study in our in Karnataka about this collusion. What is it?
Collusion.
Yeah, collusion. How many of our patients actually know what is happening to them? While many of them know the diagnosis that it's cancer, almost 70% don't know that it is incurable when they come to us.
Wow.
So it's a tough scenario because none of the other conversations are possible without these things, right?
Yes.
And they come with the expectation of that, this doctor is going to do something here. These doctors are going to do, so their health is going to improve and possibly they'll go back for chemotherapy.
Okay.
Right? Or whatever medical treatment of cancer is there. So, and when that doesn't happen, and they're getting sicker and sicker. Sometimes we don't even have too much time.
Yes, correct.
Right? And that is the point when, there's lack of trust with us, anger at the doctors, anger at the nurses, anger at the family members, because, and they accuse sometimes. It's a free place, that's why you've got here. It's that's why I'm not getting well. And we have to resolve all this. So I think one of the most important thing to understand is it's because families want to protect their loved ones. They don't tell them. It's also about having conversations with the family. It's making them understand, acknowledging that this comes out of a place of love. They want to protect. We also want to do something in the best interest of the patient. So let's discuss this. Let's look at what will happen if we don't tell and what can happen if we tell.
Correct.
And, take it forward from there.
Yeah.
Most of the time, it is the fear of telling that prevents the families from telling. Once we reassure that we will be there, we will support the fallout, the emotional distress that comes in. We have trained people who can support them through that.
Correct.
They come on board, and then it is easier to have these conversations.
But sometimes it will be that,
we may not be able to.
I cannot, I don't want to tell them. What I wanted to also know is that, is there any scientific data that backs this? When families come to us and say that he will get depressed, don't tell him. What is the evidence saying? Does that actually happen?
So actually, interestingly, there's a study which was done in Tata Memorial Hospital, right? So they asked the patients who came there with cancer, whether would you like to know everything that is, the details of what is happening to you. 80 to 85% said yes, I want to know. Even if it is incurable, I want to know about it. The same question they asked the relative. Okay, and hardly, I think more than, I'm not very sure of the percentage, but very few actually, majority of them, more than 60%, didn't want to tell because they feared that by telling they would lose hope. See, there's going to be distress when they come to know, definitely, but also there's going to be a sense of hope is not only about cure. Hope could be about fulfilling your unfinished businesses, saying your goodbyes, going for some of the what you always wanted to do,
Hmm.
doing those things.
Hmm.
We had this dental surgeon who had come to us,
Hmm.
a young girl in her 30s. She knew everything about her disease. One of her wishes, when she realized it is incurable, she wanted to go to Ladakh.
Wow. Okay.
That was on a bucket list.
Huh.
So she kept asking, would I be able to do it? Then we had to contact some doctors there, and she did go and finish it. I mean, go to Ladakh and visit, but under supervision, of course, of a local doctor. She came back. The next thing was, she hadn't told her younger brother about her illness. The thing was, she was very hesitant to tell him because his exams were there, his education will get disrupted. And we had this conversation about what would happen if she dies and he doesn't know about it, that she was suffering. What would he feel? Right? And then she realized solution can be both ways, right? It's not only with the patient.
May not want to tell
tell someone else. So then finally she decided to tell him. He took leave from his engineering course that he was doing, and he was with her for a month, and they spent a good quality of time together. They made memories, right? Hope is about that also. Memory making, leaving behind a legacy, having those moments together as a family, right? So hope can be different things for different people. So having these conversations are very important to understand what is that person's hope.
Wow. Yeah, that makes a lot of sense actually. But I also know that as a palliative care physician, actually facilitating these conversations, or even leading your team as they facilitate these conversations, can be quite a challenge. It can take up a lot of, it can be very taxing on the mind. So I'm going to flip the question and ask you, how do you cope with leading a team, or with even not just necessarily about the team, but even doing some of this by yourself?
I think it all boils down to knowing your boundaries, right? Your limitations, right? While compassion, empathy, I mean, you have to be. You know, there would be there needs to be some boundaries that you draw, right? It's never one of the things. Recently I was speaking to my good friend Michelle about, she was counseling parents of a 3-year-old, and she has a 4-year-old child. Then I said, are you okay?
Yeah.
She said, no, I've learned to keep those boundaries, not to compare.
Yeah.
Right? We say empathy is putting yourself in the other one's shoes, but sometimes it may not be very cognitive. Empathy is fine. Trying to understand what that person is feeling is fine.
Yeah.
But literally putting yourself into the other one's shoes is going to have an impact on you.
Yes, correct.
Right? So I think it's about realizing these things, being reflective enough to understand when you're crossing that boundary. That's extremely important. Second is about having a good team to support you. Maybe they say, right, it's impossible not to get affected.
Correct.
At times.
Yeah.
Right? How much ever boundaries you draw, some you are also equally vulnerable at
Correct.
points. To understand where your vulnerabilities are, and when you reach that point, to reach out to someone who can mentor you, debrief you. Right? That's the second thing that you do. Third thing, we in the mental health profession talk about personal therapy. Right? It's about finding a good therapist with whom you can reflect a lot of things. Right? From the time of psychiatry or psychotherapy, when you do, they always talk to you to have a personal therapist.
Of your own.
Yeah. Because a lot of the times, these unresolved things you carry on into your therapy, which may not be to the client's benefit. So having personal therapy gives you that space to reflect and to understand what is happening within you.
That is kind of like your own space to hold your own emotions.
And I think fourthly, it's about sublimation, what we call turning whatever you feel into something positive. So I write. So I blog, I write, I jot down my experience, journal it. So in the process of journaling, you're releasing your grief. At the same time, you're turning it to something more positive.
Sublimation is also a coping
mechanism, defense mechanism.
A defense mechanism.
So
it should be, you should know how to utilize defense mechanisms to your advantage.
So these are unconscious. So probably it comes with, your personality as you.
Some people might draw, some people might sketch.
Some people might write, some may go for an exercise, some may listen to a song.
Wonderful. I think that I've asked you quite a lot of questions about this. But the last question that we always ask our the people who come onto our show, what does living well mean to you?
What does living well mean to me?
That's the name of the podcast for us. So this is what we always ask. What does living well mean to you?
I think living well means being true to myself, right? In whatever way. It could be, for me, it's about having dignity, okay, working with integrity, and bringing about a small change, right? The change that we strive for is to ease the suffering of those who are dying.
Yeah.
Right?
Yeah.
So I think it's about that.
Yeah.
Right? It's about not compromising on my values and preferences. And when I die, I intend to go out on my own terms. That is why the living will is there. Right? Yeah. So I think for me that is important. And I always say, I don't know if you've heard of Ikigai.
Yeah.
Right? For me, it is the purpose, profession. Everything has come together in one place. My creativity, everything comes from this one space. So I found that space here in what I do on a day-to-day basis.
That's wonderful. I mean, I think that is something that people only dream of. Yes. And to have achieved all that and still be, that's wonderful.
Do make those small changes that can make a difference to one life.
Quality control, quality improvement,
small changes. Yes.
Yeah, that's wonderful. Thank you so much for coming on, Dr. Seema Rao.
Thank you so much, Smriti.